Welcome to another episode of the Melbourne Athletic Development Podcast. Today, Jack, we thought we would talk about something that came up during the week with a student that we've actually got currently with us from Latrobe University. And she asked a very valuable question, which was, we've spoken a lot about this concept that in the sort of framework that we use and the complexity model that exists for managing, complex problems, a really important way to address these issues is to run what we call safe-to-fail experiments. Not we, but what are called safe-to-fail experiments. And the question that she asks is, well, is that just trial and error? And on the surface, it probably appears that it is a little bit like that. But we thought it would be important to kind of discuss, firstly, okay, what are safe-to-fail experiments? Why might they be important in the management of complex problems or problems that have multiple inputs?
Yes.
And then maybe some examples of some things that we've been trialing and running some, small experiments to see what the effect would be.
Yeah, it's actually a good conversation to have to follow up from our previous conversation of thinking about diagnosis and what that tells us, and particularly protocol-driven approaches to managing conditions, because this is a good example of someone who, older lady, low back pain, a lot of things going on, but she's certainly got some severe degenerative changes, has quite poor metabolic health in terms of being obese, no physical activity basically, multiple comorbidities related to autoimmune diseases, joint replacements and so on. So there's a lot going on there. And a good example of what you would call a complex case, and a good example of thinking is, well, where do we actually start with this type of person? Particularly for someone like her too, when she's coming to see me for conservative management, we're going to be doing mechanical loading as a part of her rehab. But what is her system's capacity to tolerate stress?
Yeah, and you would expect it's going to be low, but if you pitch it too low, maybe you're not going to get what you want out of it. And if you pitch it too high, you might get some really disastrous first order effects, which is
absolutely
first response that she'll get from that hormetic, stress input is probably a lot of discomfort, potentially an increase in her symptoms. A poor immunological outcome might piss off, say, for instance, her autoimmune symptoms quite a bit, and then she's never going to want to see you ever again.
And for someone like her with all these comorbidities going on, she's also had really compromised sleep recently because of her pain on a background of quite poor sleep. You start to think about, well, what are these, like thinking about her hormetic profile, thinking about her adaptability based on her age, thinking about the maturation of her system based on her training history, which is basically non-existent. My expectation for her in terms of how much stress she can tolerate is quite low, particularly in the current situation where she is in quite a severe amount of pain. And the last thing I really want to be doing is aggravating her symptoms, particularly when she's in quite an elevated state.
So when you've actually gone through that process of assessing and asking those questions and trying to get some quantification of, okay, how much exercise have you done? What's your current level? You start categorizing and putting that into boxes to sort of profile, okay, you're at the lower end of this capability.
Absolutely.
This comorbidity puts you at the high risk of this. Your ability to deal with this mechanical load's probably low. That's where it's slightly different to that trial and error thing, in the sense that you're creating an educated profile of this individual. You're creating an understanding of what we talk about, the hormetic profile. You're trying to get an understanding of what that is, so that you can then start to put together. It is a trial, but you're putting together some sort of experiment that you think, okay, what's the safe level to pitch this at?
Exactly.
And it's different, I guess. Sorry, just to
go on.
It's different probably to when you're working with a adaptable system. With trial and error, you're often doing it with something that's maybe a mechanical system, like, we're just going to try this, didn't work, it broke, or it didn't. You can't afford for it to be not safe to fail. Like, it has to be safe to fail. If in a trial and error, the big differentiation for me is that in a trial and error situation, say with a mechanical system like a car, if it breaks, it's not really a big deal. You can't break an individual because, well, there's lots of reasons you probably could break them, but you would prefer not to.
It's funny, the thing I think of straight away is I remember at school I did or the equivalent in Queensland of methods and specialist math. And sometimes we get a complex problem and I go, by deduction, I'm going to use a trial and error method.
Yeah.
And the good thing is if you didn't get the right outcome, it doesn't matter. You could actually have a go at doing it again. We don't have that luxury, obviously, when you're dealing with humans.
Yeah, because you can't afford for there to be too much damage accumulated from the input that you've got. So you've got to pitch. There's a little bit more conservatism to the type of trial that you will do or the experiment that you will do.
Absolutely. And there's a lot of things to consider because for most kind of patients we're seeing, they're going to be presenting with some type of pathology. What's the appropriate mechanical stimulus that you can apply to obviously not irritate or aggravate their symptoms or potentially, further aggravate their pathology? At the same time too, what's the appropriate mechanical stimulus where you're going to get some positive adaptation too? Because there's also the issue that you can have of applying a lack of stimulus and therefore getting nil effect. But the other thing to consider then as well is what is their response over time? This is where we need to think with regards to adaptation, something we've talked about when we think of hormesis of that primary versus secondary response. Because yes, we need to be considerate and cognizant of that primary response not severely exacerbating their symptoms. We may see some adverse effects associated with applying a mechanical stimulus, and we can think about what those are from regard to things like DOMS or muscle soreness. For this individual having very little or basically no physical training history, it's very likely she's going to experience some of that. But then more importantly, is she going to get the secondary response that I hope for her to achieve? And part of that can be associated with her symptoms. But also, how long is it going to take her to get that response as well? Because given the fact that she has a lot of poor health markers, her system's ability to adapt
is going to be blunted.
Is quite low, and that's quite.
Or you'd expect it would be blunted at least.
Yeah, and this is something that it's very important to think then too of what's actually regulating this, because when we apply mechanical stimulus, when we talked about this concept of mechanotransduction, you're creating mechanical signals that get transferred into chemical and electrical signals that upregulate certain
molecular pathways,
and therefore, like at the nucleus level, DNA to create, say, new tissue. But the other thing to understand though too is that response is tightly regulated by the immune system. And I think that's something that we need to really highlight, that if you think even just from muscle hypertrophy level, when you think about satellite cell activation, proliferation, differentiation, the myoblasts and so on, that is all regulated by the immune system, by certain cytokines and macrophages providing the signals to the tissue to go, this is what you need to do in this particular order and process. And that's very influenced by that individual's hormetic profile. So if we need to really think in a much more holistic sense of what's this person's health status and how does that influence the type of interventions I apply with regards to intensity, frequency and so on.
Yeah, because I think this heavily fits into obviously why we see different responses from individuals based on whatever intervention we put in place.
Yes.
And it builds on obviously what we were talking about in the previous discussion around, as we mentioned, the diagnosis and what we see in terms of the symptoms.
Absolutely.
And now this is kind of the next step of what we see from the intervention. And we mentioned that obviously, people respond differently to the same pathology to their tissue. And one of the things that I think is really important about this idea of building these safe to fail experiments is taking that information and then being willing, and there is a little bit of professional courage, I would say, that you need to develop to be like, okay, I'm going to trial this. I believe it's safe. And then, with the consent of obviously of the patient, go through that process, explaining to them along the way, we're going to trial this. We want to see what the response is. You may see or experience an increase in pain, or, these are the symptoms we need to monitor for. And the part that I think is the most relevant is bringing that patient along for that journey and them understanding that process. That it's not that you're guessing and just, as I said, throwing trials of anything that has potential.
Absolutely.
What you're doing is trying to guide their system to a place of the best healing as possible by exposing it to stresses that you think are going to be beneficial.
Absolutely.
And that can be tricky because sometimes they don't necessarily want to feel like a guinea pig in that process.
Well, yeah, it makes me think of that straight away in terms of the psychology of taking that approach, because again, on the other end of the spectrum of following this protocol of one size fits all.
You're very certain with someone. You say,
totally.
We're going to do
First
this for 2
1,
weeks,
yep.
then this, then this, then this, and the patient goes, great. My therapist, my doctor knows exactly what they're doing, and this is the protocol that we're going to go down.
Yeah, no, it's an interesting one, because the reality is too, and this is probably more relevant for those gradual onset types of presentations. We have to also monitor our expectations of what their response is in that acute and subacute state, because it never ceases to surprise me, and this is actually even probably more relevant with more acute injuries. If you see someone within that, say, first 3 days, their initial presentation is very much influenced by the immune response to the damaged tissue, and also the individual's perception of that situation, because that can certainly amplify the severity of their symptoms and even potentially the amount of deficits that they have. But then when you get into that more subacute phase, you might start to see quite unexpected or non-linear improvements in that person's capacity. So that does also provide some challenges. And how do you usually approach that, do you think? Do you think it's really just comes back to how you actually monitor expectations? Or?
Well, I think, it's about having the open conversation with them. And sometimes, it sounds weird, but you almost present to them options. I've been doing that a little bit, where I say, okay, this is what I think is worth going down the path of, but I expect that we might see this. Obviously getting their informed consent. Are you happy to kind of trial that? Because it's a difficult one too, because sometimes in the more complex cases, you're dealing with other health professionals. You mentioned that patient, you're dealing with someone that's referred them who's actually a spinal surgeon. In the case of some of the stress fractures I'm dealing with sports medicine physicians who are giving me guidance. And sometimes the patient in the middle feels like, well, hey, as I said, I'm not a guinea pig. And you have to kind of present them with the scenarios, and that often, as you said, comes into the psychology of that individual. What's their general risk profile like? How do what's their personality when it comes to a trialing things? And we have a society that varies a lot.
Yes.
Some people like to take risks and they're willing to try things, and sometimes that's part of the success of the things that they've done, and sometimes it gets them in trouble. So you often get athletes who, if you present them a more aggressive rehabilitation protocol or strategy or safe to fail experiment, they're willing to try it. They're not really that concerned with increased pain the next day.
Yeah, absolutely.
They actually just want to get better more quickly. And I think that opens up some concepts and some ideas that we mentioned when we spoke to Paul Coburn, around probabilistic thinking and starting to offer a really interesting union with your patient, where you're working with them collaboratively and you're saying to them, these are your options, these are the probable outcomes, right? And they might be opposite. One might be like, you feel fine. One of them is you pull up really, with a more increased pain. One of them, and it keeps varying depending on what obviously the stimulus that you apply. But having them part of that process, and it's a really interesting game, that one, because it goes very much from that paternalistic kind of relationship to being much more of a collaborative one. And to me, that's a lot more fun. It's a lot more interesting, and I think it's a lot more empowering to the patient. However, they do need to have some level of nous about how they interact with the clinician. And for some people, that's difficult because they don't necessarily make decisions like that, and they don't necessarily think in that way. And that can require some education, I think, on the patients, and even from our part as the clinician, on how to think about a problem in that probabilistic nature.
I've got a question for you then too, thinking of safe to fail experiments. How do you address a situation when you do fail with a patient? Even though it might be, as the name suggests, it's safe to fail. So it's not like you're causing detrimental outcomes, but the expectations are not being met about what you see as the probable outcome or what they see as the probable outcome.
I think it's mostly about having the conversations before. It's about saying these are the likely outcomes and being very open about this outcome over here is a negative one for you. It doesn't heal well, we re-injure, we have, all of these different things. Are you still happy and consenting to go down this path of management? Because if they're not, then you don't go down that path. Like your job, I think, as a clinician is not necessarily to tell people what to do. It's very much to guide them. And we had some of that conversations when we spoke with Katrina Borg about, what do you do with someone who isn't following your advice? She spoke about that boxer who really wasn't sticking to the plan and was cutting too hard and all that kind of stuff to make weight. And your job is not to abandon that person when they don't do what you say. That's not what your role is. Your role is to be a support structure within that environment. And you can say to them, I do not believe that the approach you're taking is going to be the best outcome for you. However, I'm going to support as best as I can what you're trying to do. And that's a difficult process. There's probably times where you're in your head thinking, well, this is definitely not going to work. But you can only educate on that. You can't force someone to do anything, obviously. So I think it's mostly about that conversation that you have beforehand and go through that process of, okay, these are the likely potential outcomes. And a really good example, I think, of this is when you're managing someone, say, with tendon pain. So you could say like a lower limb tendon, like an Achilles. You might say to them, okay, today we're going to trial doing some, we're at the point where we're ready to start implementing some jump training, some plyometric tasks. You say to them, like, all right, we're going to introduce this. All right, I need you to report to me if you're getting some soreness tomorrow, how you pull up. Often morning symptoms are one of the key indicators for how someone's tolerated something like, tendon loading. So I need you to actually let me know what happens with that, because one of the outcomes that we could have is that you actually, you pull up sore from this. So I think it's just about those conversations. If it's something that's potentially, say, a long-term, there's long-term ramifications, it's a deeper conversation, and it needs to be, I don't know if it needs to be in writing. Obviously we'll put it into our clinical notes as they consented to go down this path, but maybe there's value in that. And one of my mentors for coaching, not that it's in a medical sense, but he's often said to me that sometimes you have to be really careful with athletes who, might be having sort of behavioural disruption within your group of athletes, whether it's in a sporting team or whatever, and you almost have them almost sign on the dotted line and say, we're going to do this as an intervention to help you, with the way that you're interacting in this group. I need you to commit to this process, and I need you to be willing to understand that if you don't meet these, then you're maybe not the best person in this environment. And not that it's the same in the medical environment, but I think it's a similar process. Like, you need to almost sign off on that. One outcome could be that this heals really well and you don't get re-injured and you return back to your activity. But another outcome, if we go in this pathway where we're trialing things and we're using these safe to fail experiments, is the actual symptoms potentially get worse and we need to revert to a different option. Are you willing to go down that path? And that's a very different process for a patient to go down. And some of them are very open to it, and I think they really like that. I think younger patients, in my mind, off the top of my head, seem to be more open to that because they like choices. They like to be more collaborative with it. Older patients, not necessarily. They kind of just want to be told what to do, and I think that that's a little bit cultural when it comes to age and that more, as I said, almost paternalistic kind of relationship that people have
do
with,
as I say. So
have with medical practitioners.
Do you think that's a problem though too?
What's that?
When you have those personality types who just want to be told what they want what to do, basically.
Yeah, definitely. I think that can be a real problem, and it's very difficult, I think, sometimes to treat those people because they're very reliant on you. And there's nothing, I don't know, as like a clinician, I think there's nothing worse than feeling like this person has put all of their faith in you and they expect an outcome from you that in your mind you potentially can't deliver. It's funny because I asked a number of the surgeons that we had in that same question, how do you feel about being the last stop on the road? And some of them were really good about saying, like, you have to actually really go through those expectations. Some of them didn't answer it, right? Because I think that's one of the things that takes the toll on clinicians who care, and a lot of us do. We really care about the outcomes for our patients. Is if you do something and it doesn't work, how do you actually manage that internally? We're all proud. We all have egos. We all want to be good at what we do. We all want to get good outcomes. So that can be a difficult thing, I think, when it doesn't work out how you want it to work out, or they wanted it to work out. So how you manage that, I think, is a lot of being very open, having those conversations.
The other thing I think too about the importance of setting up safe to fail experiments is your ability to be innovative or creative in tailoring solutions to an individual.
And I think this is one of the best things about our profession, particularly in an environment like this, a private practice environment. And I know that we brought this up with a couple of the surgeons as well. Like, surgeons seem to have that want to be innovative. And I think it's one of the most fun parts of our role is that the knowledge is expanding, the evidence is growing, and there seems to be more ability to actually explore things and try things and innovate.
And particularly in an open environment where, we don't have the luxury of being able to control all the things that we want to. And so more often than not, you're going to be applying multiple interventions at once, and not to mention things that we've talked about with considering other non-physical or systemic factors that you associate with someone's presentation, and thinking about, well, how do I actually configure this stimulus and this stimulus and this stimulus to see the emerging pattern that I want for that individual. And this is where I think it's actually, you always need to go in with an open mind when someone presents with a particular problem, because you actually don't know how that individual is going to respond. I mean, you have obviously indications, and if you've worked with that person for a long period of time...
This is such a good point, Jack, because I think this is one of the things that I struggled with the most as a younger clinician.
Yeah.
Was the amount of uncertainty that you keep being presented with, right? Like, as I said, we all want to get good outcomes. So you would love to be able to say, if I do this, I'm going to get this outcome. And we've spoken about it so many times about complex systems and biological systems, and how that's not what you get. A plus B does not always equal C. Yeah. Often it doesn't equal any of those, equals 7. And you're like, well, how does that work?
Well, and this I think becomes more obvious with types of presentations where the timeline is larger, because you see the more significant difference of, if it's a short-term injury, 1 day or 3 days, it's not that big difference. But say post-ACL reconstruction is a great example of, the average idea is 12 months, but it
varies.
You've seen people that get back as close as probably 6 months to 18 months.
Yes.
It's quite significant. And I always find that interesting. There's a young girl I've been working with who ruptured her ACL, had reconstructive surgery. And when the first time I saw her physical capacity to begin with is just unbelievable in terms of positive, in terms of, not the typical restrictions in range of movement, able to produce force through large ranges of movement. And it was so unexpected to what you typically see. And it's like, well, what is it about this individual that allowed her to have that response? But again, the thing I'm trying to highlight here is it didn't meet my expectations. Was I going to focus initially on restoring end range extension? Well, she's done that.
Yeah,
we don't need to worry about that.
Yeah,
she was at a much further or progressive stage than what I would typically expect. But it's interesting because again, if we could follow a certain protocol, which would be like, well, I need
we're
to
doing
focus
range
on
at
these.
this point. Yeah,
exactly. But where is she based on what I identify as being the deficits, and what are the things that I need to actually do to apply enough stimulus to see that change?
And I think that's the thing that, there's been a number of different papers come out on different areas of injury management that talk about this, more of a checklist type system. And I think for those people that have used that in the past, this is what we're kind of talking about, is if someone's meeting the criteria to move to the next level of stress application, then you can start to progress them along that journey.
Absolutely.
Now, there are certain pathologies where you want to respect tissue healing. We've spoken a lot about bone healing in the past. Like if someone's actually had a complete fracture from some traumatic injury, even in the presence or non-presence of pain, you are going to respect that it takes a certain amount of time for callus formation and the development of actual healthy bone tissue that's hard enough to be able to withstand the mechanical loading.
Yes.
Right? However, it's important to kind of recognize too, if that is not the case and you're not concerned about the actual structural integrity of that tissue, that you can progress them along based on the observations that you're making. And I think that is one of the key differences between a timeline protocol and maybe a checklist system and this idea of, as you said, these safe to fail experiments. Like if you can pass this, you can go to this next level.
Yes. I think something else that's worth talking about here too, when we think about the importance of creating novel solutions and having an ability to be creative and innovative, is thinking about different types of stresses we can apply. And I know something that we have been applying a lot this year is looking at something like blood flow restriction.
Yeah.
It's actually interesting because I know for me, my perceptions of blood flow restriction training for the population groups we work with has changed dramatically, because I always saw it as something that you give to typically older people with very low physical capacity.
Or even post-surgery.
Or post-surgery. People who basically cannot tolerate high mechanical stresses, because ultimately the way that blood flow restriction has a positive effect on tissue adaptation is creating high metabolic stress, being able to create a lot of peripheral fatigue that allows the recruitment of larger motor units, and therefore creating that mechanical stimulus necessary to the muscle fibers innervated by those motor units and to get them to grow.
As I said, this has been an interesting experiment for us. And again, I think this sits into, even as our clinical practice, one of the safe to fail experiments that we've been enjoying exploring.
Yes.
Right? Yeah. Which I think our understanding, as you said, has changed. And I know that there's literature growing on this, on what the effects are. But what's interesting is, I think both you and I, and we discussed this before starting this discussion, is that we are seeing less and less likelihood that the improvements are coming from that mechanical stress. Or at least we feel that that's the case. We're seeing really good outcomes post, say, muscle injury. We're seeing really good outcomes with managing tendons. There's been discussions, we've been using it quite a bit, even with things that are relating to, say, bone turnover. So things like shin splints, we've been seeing really good outcomes with that kind of that presentation. And to me, I think it's starting to address an underlying feature that we have discussed before, but we might sort of explore it a little bit more, which is because of the mechanical stress that it creates, the metabolic stress that it creates. That is, you get all these byproducts building up within the tissue because you actually are forcing a level of hypoxia. The actual stress that it creates is more systemic than it is necessarily localized. Now, there is a localized stress response to that tissue.
Absolutely.
You're going to get a huge amount of, say, lactate buildup. You're going to get a huge amount of hydrogen ions. You're going to get all these different changes within the tissue because you're actually stressing that area with a lack of the ability for it to draw on the blood supply. But I think the effects that that's creating systemically is enormous. And we've spoken about this before, and I'll lean on your knowledge here, but the effect that actual metabolic conditioning has on the immune function of that individual, their health status, and what that actually means for, say, their ability to deal with training stress.
Well, a good way to start this conversation is think about, in, say, conventional resistance training, what's the typical process of progression that a lot of coaches will advocate for? Well, particularly with someone with very little training history, you get them to do, what you call strength endurance or hypertrophy stimulus. So that is relatively moderate loads, but higher volume. And the idea or expectation of that is you need to build that foundation where they can tolerate that type of stress prior to going to heavier loads, so that they can actually maintain performance and also not get the negative things associated with doing repetitive heavy loads. It's interesting because when you think about it, it's like you can actually get hypertrophy from doing heavy loads if you just did, say, less reps but more sets.
Yeah.
But you can't do that. Well, you can try, but as you often see in the real world, people will fail over time where they'll start to get that overtraining effect. And it's something that I've thought about. I'm like, well, why is that the case? Like, what is the difference between doing that more moderate volume, moderate intensity, high volume versus heavy intensity, low volume? And the big thing is related to, well, the obvious ones is with the moderate intensity, you're applying less mechanical load, but you're actually still applying a lot of metabolic stress. And that is, you're creating more repeated contractions that requires the tissue and the central nervous system to have repeated contractions. As opposed to when you do those heavier loads, obviously you're going to create metabolic stress as well, but you're also creating a very high mechanical load that tissue has to then, or your whole system has to tolerate with.
Yeah, and so, the byproducts that you get from that high mechanical tension can be very taxing on your immune system to have to deal with afterwards.
And this is the big difference, is both of them are applying a certain amount of metabolic stress, perhaps more the moderate intensity, a little bit more, but the heavy training is going to apply a lot more mechanical stress. And that requires adaptation within the actual tissue structure and integrity. As opposed to when you just apply that metabolic stress, you're still going to create a large oxidative stress response. So thinking about the actual metabolism of the cellular components, particularly like the mitochondria, it's going to secrete certain metabolic byproducts. It's going to change the local pH environment and create a lot of positive ions that your antioxidant defense system has to neutralize. Now, it's really important to remember that we actually need oxidative stress to induce adaptation. They actually provide really important signals. And that's where you have to be careful too of, the idea of, let's give people lots of antioxidants like high vitamin C can actually negate adaptation because you're not allowing oxidative stress to
this
occur.
reminds me of the whole immersion in cold water. And the research is becoming clearer and clearer that, there is benefit to, say, soreness with cold water immersion, but if you're doing it, say, in high training periods, you're actually blunting these responses that you need for adaptation. So, the research that's sort of been slowly pushing, and even if you look at some of the recommendations from, say, the AIS on this, is use cold water immersion, say, in competition or in tournaments, or things where you've got a shorter recovery time, and adaptation is not what you're after. Then you're not trying to get physical training stimulus adaptation in a tournament. You're just trying to play at the highest level possible, versus when you're in a pre-season and you want that stress. You don't need to you want to recover from it, but you want that recovery to happen in a way in which the stimulus that you've applied actually does something to your overall system or that tissue.
Yeah, and so like going back to the value of doing higher volume, more moderate intensity, because you're creating a large metabolic stress but actually controlling the mechanical stress, you're building up your body's ability to deal with inflammation and oxidative stress from mechanical stimulus. So that then allows you to then go into periods where you do have higher mechanical stress to create more structural or neural changes to the system. But it seems that you need to have a balance between those two things and potentially cycle between the two. And so this is where I think a lot of the benefit we've been getting with blood flow restriction is we're still providing we're providing a very high metabolic stress. So we're getting certain systemic responses associated with that metabolic stress. And we're still creating some mechanical stress to the tissue and potentially more to the fast twitch fibers because of that accumulation of peripheral fatigue that allows them to maintain certain tissue properties like cross-sectional area. But it controls the amount of mechanical load that they apply. And I think this is actually really important and relevant for, say, like some of your athletes because they're dealing with such high mechanical stresses all the time. We need to think about, how do we actually apply enough stress to maintain certain tissue properties and, say, cross-sectional area, but still actually control the amount of mechanical stress. But I think also then too is, particularly when you think about your sprint athletes where intensity is such an integral component to their training and performance, how do you create metabolic stress for them to actually build up their capacity to deal with the accumulation of inflammation and oxidative stress that they get from their training without applying a lot of mechanical stress in itself.
Well, I think that's a big feature because we see this where a lot of coaches will then say, okay, well, let's do lots of low level kind of tempo training or aerobic type stuff. That's not there. It's not actually there to make them faster, but it's building these, as you said, metabolic systems.
Yes.
And potentially, as you mentioned, you can do that in other ways. Potentially, you can do that by applying these stimulus in a gym setting, or even at a low level. They might just be walking around or doing drills with the blood flow restriction on, and that is the thing that creates that metabolic conditioning rather than necessarily having high mechanical loads. You know, like people will often try and do, say, large volumes of tempo running, and that will start to develop those underlying low-level metabolic conditioning, but, you know, it's still a lot of contacts.
That's the thing, you're still applying a lot of mechanical stress,
and, you know, people get used to that and it builds up, which is a good feature of why you would do those things. But, you know, there is downside to it as well, and potentially, as I said, getting some of those changes might be useful in other settings.
Yeah, exactly. So I think what this highlights too, and we've talked a little bit about this with, say, team sports and thinking about different fiber type profiles within a team sport, of how do you apply adequate metabolic stress so that they can actually, say, depends on team sport, it's going to be a little bit different where they need to have repeated bouts of effort, but also making sure that you don't apply excessive amounts of metabolic stress that you might see a compromise in their performance and potentially an increased injury risk because you're not applying the appropriate conditioning stimulus for that individual profile. Yeah,
I think that it's been one of the more interesting parts of this kind of exploration that we've had. Do you think that, like, how we've kind of been applying this and what we've been seeing, that the benefits that we're getting are almost more systemic?
Oh, look, absolutely. I think this is something that we need to always remember with regards to not just health but performance. It's your body's ability to maintain or continue adaptation over long periods of time. Because I think one of the issues that you see particularly with athletes is, can they sustain adaptation over the year, you know, when you break that up into thinking about off-season and during in-season stuff. Because part of the issue that you get associated with doing lots of training stimulus is not just the breakdown of their musculoskeletal system. That may be a particular outcome associated with it, but can they actually deal with the actual systemic stresses associated with the actual training stimulus itself? And this is where I think something like particular stimulus that can apply metabolic stress can really help. And this is where I think it's really important to think about even other types of stresses that create positive adaptations to the system that still control the amount of mechanical loading. Like a good example is, say, for instance, heat or cold therapy. Because, for instance, even cold therapy itself can be actually a very useful stimulus if applied in the appropriate setting, thinking about in terms of when it's done in regards to other types of training stimulus.
Yeah, and the question I have for you then is, do you think that there's a point where you can do too much of this metabolic loading? You know, we spoke about a conversation with one of our colleagues, Jeremy Weeks, you know, and he spoke about some papers that he'd been looking at that demonstrate that with distance runners, if they do too much aerobic training, these systems seem to be overloaded a little bit, and that's where you start to see immunological function actually start to deteriorate. You know, I think swimmers have a lot of problems with this, where obviously because swimming is non-weight bearing, the amount of swimming load and volume that they can do is enormous, right? Because the mechanical tension they're creating is not that high. But what then they have is that they can push their metabolic stress so high that their immunological function actually starts to...
And metabolic dysfunction itself. Well, like it's kind of two examples of the extremes, because, you know, for, say, your type of athletes, you need to try and control the amount of mechanical load,
Yes.
put it more better, they need to expose themselves to very high mechanical loads, and the amount of actual metabolic stress that they're getting is going to be limited based on the parameters of the training that they're doing. So how can we apply metabolic stress with limiting the amount of mechanical stress? But on the other end of the spectrum, where, I mean, obviously long distance runners or swimmers is maybe a better example, where you're not applying as much mechanical stress, but you're certainly applying enough metabolic stress.
Yeah.
How do you find that balance between the two things?
I've been thinking about this a little bit because I have noticed this, and this is just an observation that I've made, but I've noticed this pattern where athletes who have gone into, say, a sprint sport like, I deal with, track and field, and they have a history of playing, say, team sports, AFL, soccer, basketball, whatever it is. And growing up, they had no injuries as they were participating in those things. But then as they specialized and only did those, that very high mechanical load activity, even though they were training a lot and they were doing all the things that you would consider to be, effective for the development of that sport, they would still have, say, a lot of, say, soft tissue injuries, or the recovery pattern would be slow.
Yeah.
And another example that I noticed of this was someone who I helped over a number of different seasons. They were playing soccer, and he'd grown up playing soccer. Then he decided he got really interested in the gym and sort of did a few years of powerlifting, put on a lot of muscle mass, got really strong, but wasn't doing really any sort of metabolic conditioning, wasn't really doing any sort of soccer play or anything like that. And then decided, okay, I'm going to go back to soccer. I enjoy playing, and he's playing local league, but just kept having injury after injury after injury. Even though if you measured him on all of his strength parameters, he was higher than all of his teammates. He was doing the pre-season as it was set by the team, and at the time, and it's become very popular to do more intermittent, high intensity training for preparation for team sports, MAS type running, maximum aerobic speed stuff, intervals, rather than the old school, like, go and do some jogging, go and do some of these underlying these metabolic kind of conditioning. And we actually did a couple of seasons of this, and he was getting so annoyed because he kept getting injured. And so I said to him, I was like, I sat down with him, I said, okay, we need to start thinking this a little bit more broadly. And I said, one of the things I think maybe you would really benefit from is going back and doing a pre-season, this next coming pre-season, where we actually do a lot more old school aerobic type conditioning.
Yeah.
I was like, I want you to start jogging. Yeah. I want you to start doing more of this. I want you to start doing more of that. More classical loading when it comes to your running for pre-season. And that was the best season he had by far in the previous 3 seasons. Nothing changed with his gym loading. Nothing changed with his match play or soccer training. The big thing that changed was the way we structured the pre-season. And the more I think about that, the more it's like it was returning some of those metabolic features which had probably been heavily depleted when he decided he was going to undertake, powerlifting.
Yeah, and I think this is where it's important to think for an athlete, the more they specialize, the more there's that potential for divergence of, say, health and performance, because they're becoming much more specific with their training stimulus. I think it's one of the things we need to remember when you think about specificity of training. Like, absolutely, it's important. It's the fundamental element. But the more you become specific and you lose that diversity in training stimulus, the more limited your system becomes in terms of its ability to, what's the word I'm looking for? In terms of its diversity, I guess, is probably the better way to look at it. So I think that's a common error, or not error, but an issue that's associated with athletes, particularly if they work in a sport where there's very, very limited qualities that they need, is their particular training becomes more and more refined, and they lose the diversity within their system in general that actually makes them more compromised to injury. And I have another example myself, is a colleague of ours who had an athlete, an AFL player, who had a calf injury and ticked all the boxes when it came to being able to tolerate high mechanical loads in terms of high force, high velocity, could have very good strength endurance, very good strength capacity, power, elastic function. They ticked all the boxes associated with thinking that there is the structural integrity required to deal with the training and the game.
And the playing, yeah.
But then they went back to playing and they failed and they had a re-injury. And it's like, well, what's going on here? Has it got to do with the structural integrity of the tissue? Probably not. They seem to have ticked all those boxes. But when you think about AFL, there is a very high
fatigue and
metabolic stress associated with it.
The game goes for 2 hours.
Particularly when you think about the calf in particular. And it's like, well, did that individual have the metabolic capacity to tolerate the volume of the training and the gameplay? And well, I think we've talked about this before, but it makes a lot of sense when you think about the thing that determines the performance of a tissue is the active stiffness. And active stiffness is based on the ability to maintain the energy input required for the tissue to work. So if you don't have that metabolic capacity, you're going to have compromised ability to maintain that active stiffness when you fatigue, which starts to change the stress-strain relationship of the tissue, where then eventually it may fail.
Yeah, and I think that's such an important factor. And I think it's one of the things that, we're obviously talking about this because this is sort of some of the area that we've been exploring. But I feel like it's one of the things that's really worked in this experiment. And we didn't know what the outcome would be, but with changing some of these features for these people, I think as we go forward, we'll probably start to profile even more of like, you really need this, and how we apply it might be even different compared to people who don't need that stuff.
Well, and look, the thing I find interesting too, when you briefly mentioned this before, is seeing the positive adaptation you can have on, say tendon or bone. Because I think of, say, tendon, and we always think about being able to maximize the mechanical load through the tendon because that provides the signal for mechanical adaptation, which is true. Yet, and there's actually some research now emerging showing the positive effect of using, say, blood flow restriction to create a metabolic stress and positive changes to the tissue structure of a tendon. And when you actually think about it, that's not surprising at all, because one of the big factors associated with developing tendon pathology is type 2 diabetes. What is type 2 diabetes? It's metabolic dysfunction. It's your body's inability to be able to regulate blood glucose because of the insulin resistance. And so, I'd starts to make me think of, when you apply a high amount of metabolic stress, you're creating changes at the cellular level, even to, say, the function of the mitochondria. How does that actually influence the maintenance of the tissue homeostasis? And similar again too, there is some research too looking at the positive effects of metabolic stress through blood flow restriction for bone. And again, it may be the actual mechanism there is a little bit different, because you create a high compartmental pressure and it changes the fluid dynamics within the bone, which seems to be a big regulator for bone adaptation. But it starts to make you expand your ideas of how you actually create tissue adaptation. And without a doubt, mechanical stress is usually going to be the primary factor, but it's not the only factor. And more importantly, we need to always remember that it's not just about the mechanical stress you apply, but then how the tissue responds to that mechanical stress. And that's when you start to really appreciate how other systemic factors greatly influence how the tissue responds to the mechanical stimulus over time.
Yeah, definitely. I think, as I said, it's really highlighted some of these features for us. I think one of the things that we're starting to look at now with it is, how do you quantify like what that stimulus does, right? And when it comes to, like you apply this. But the other big thing that I've, and we'll leave that aside for a second. The other big thing that I have noticed, and I think that it very much fits into the stuff you just mentioned about the systemic changes, is how much I think it regulates pain perception, right? Okay. And we know that obviously metabolic stress in itself is going to have an effect on the immune system. And I was having this conversation with the VIS physiologist, because he was talking about, say, with bone injuries, for instance, where people will say, you know they've got some sort of underlying sort of bone stress starting, say in their tibia, for example, and they'll go for a run and say, oh, it kind of warms up. And we spoke about this briefly because I sort of, in my mind, was thinking, okay, yeah, that makes sense. There's some, other features associated with the pain perception. Because what happens is as you get fatigued, obviously your brain and the perception that you have is going to be diverted away from, say, pain signals and things like that. So it's like, you're kind of a bit stupid by that point. You can't really perceive it. And I don't know if this is what we're seeing with some of it, but I think that there's two effects that happen. One is the short term, where that metabolic stress actually maybe does change the perceptual stuff that's going on at that time. Because I've seen a number of patients who, even one that was having actually sort of shin splint type pain, bordering on that idea of potentially developing into a stress reaction. And they do the BFR for some, say, calf loading, and then they'd say, oh yeah, the pain's actually gone down quite a lot. Right, so that tells you maybe there's other features involved, but to me that starts to suggest, okay, that metabolic stress actually probably has some changes that it creates from a sensory input. I don't understand the the neurophysiology of how that works, but I'm sure there's probably something, and I might actually speak to him more about that. But the other thing that I've noticed is over time, it seems that a lot of the underlying, say, immunological stuff, or that that background inflammatory kind of response that we talk about that ramps up people's nociceptive input seems to diminish, right? Because I feel like their immune system is getting healthier. Now, I don't have anything to back it up, but it just seems like that.
Yeah.
And so they'll report a lot less general pain, and more so than in the past where you've done just a series of mechanical loading. You might have used a similar mechanical loading strategy, but if you're doing it in the presence of this, say, blood flow restriction, and it's, obviously causing more metabolic stress to the tissue, I've been noticing that their pain perception goes down over time, and I think that some of it's got to do with that immunological regulation. That's a theory that I'm kind of building. I don't have anything necessarily back it up right now, but that to me I think is an interesting one, and it's because, as we speak about, like that underlying level of inflammatory status is lower.
It's interesting you say that. It's something I've thought about, and I don't know if there's any actual research being done on it, but of using, say, potential dietary strategies in that acute injury phase or in pain to actually positively regulate healing. Like a basic example, maybe say fasting to induce. I'm not sure if you pronounce it autophagy or autophagy. I know probably
doesn't matter.
Tomatoes, but in the sense of you're going to get a positive response to your immune system, which we know highly regulates the healing process, and also potentially the nociceptive response too, because of how it regulates cytokines within your circulation. I mean, and obviously you need to think about timing of other nutrients that help optimize tissue healing as well. But it's something that I don't know if it's been considered, or whether people actually use certain protocols to try and enhance the adaptation.
Yeah, I have been thinking about this a lot, because I reckon it's one of the factors that when people are eating a lot and often, that their metabolic system is in some ways, and their immunological system is stressed, because it's actually the machinery is working a lot to sort of process that food and maybe break down any of those things that potentially are dangers or threats or whatever, and there's a lot going on.
Well, and like a good example too is thinking about the detriments of, say, alcohol consumption. Like we know that has a really large impact on your ability to recover. We know that it can create a large inflammatory response. And
part of that inflammatory response is more than likely going to be the amount of machinery that has to be utilized to process the ethanol. Because I always find this funny, like people probably laugh when I say this. If I ever eat a lot of calories or I drink alcohol, I notice that I get into bed and I'm really hot. It's like my system is trying to burn through this stuff as quickly as possible. It's like all the metabolic machinery is like process it. And it's, I think it's sort of, in contrast to what you're saying, is if you're telling someone to eat a lot all the time and they're always eating a lot of calories, potentially all the machinery is like always metabolically very active versus when you unwind it and you say, no, take a period where you don't eat anything and it has the opportunity to kind of slow down. Now, there's a balance there because you don't want people with very low resting metabolic rates, because that can then have long-term detrimental effects.
Yeah, absolutely. Well, look, it makes a lot of sense too, because when you think about what, say, fasting does with, say, autophagy, is it allows your tissue to essentially regenerate itself to a certain extent. And in fact, that seems to be much more sensitive to, say, tissue with low metabolic rate when you think about, say, articular tissue or tendon tissue, where you see an improvement in the capacity for the tissue to regenerate by breaking down degrading tissue and using those biomaterials to then build new tissue within that environment. And when you think about it, that's something that's going to be really important for tissue that has low metabolic rate, because one of the limiting factors is providing adequate nutrients to that tissue to be able to build or at least maintain the extracellular matrix and also maintain its integrity, so to speak.
Yeah. What I think, as I said, I think we probably should circle back and sort of see how that all fits together. But I think the key things from this is, if you want to use this approach of safe to fail experiments, the key features are, being willing to kind of explore that individual and their profile enough so that you can start to put together some ideas on what might be safe levels of the stress to apply.
Yes.
You clearly then need to be willing to monitor it very closely and get the collaboration of that, that individual, so that you're getting feedback that is appropriate. And then be willing to be adaptable yourself based on the outcomes that you're getting, because I think that can be the challenging part of, if it's going in a direction that you don't want and you're consistently seeing that trend, then you need to change course. Yeah. And that can be difficult if you've kind of built this whole theoretical concept of like, yep, this is going to work, and there's evidence behind this and blah, 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 blah. And that can happen with a protocol, it can happen with this approach. But if you start going in that path, it's not working, it's like, you have to be willing to kind of change. Otherwise, you're going to end up in a destination that you don't want to be at.
Yeah, and that works in twofold, in the sense of, when someone presents with a particular condition, you create parameters to what you think is acceptable in terms of their response and their symptoms, signs and symptoms over time. And so you need to think of, do the parameters that you think they can tolerate based on the mechanical stresses or any type of stress you apply meet what they actually feel and experience, and also understand that those parameters are a moving target. It's a very dynamic process where what may be appropriate for them today may not be appropriate next week, in terms of being excessive or, more often than not applying enough stressor.
Yeah. I think that probably covers off on most of the things, doesn't it?
Yeah. Well, I think the other big thing to take away from today's session discussion too is thinking or expanding on how different types of stresses can induce positive adaptation.
That might be something that we kind of explore in another discussion.
Well, and look, I think for ourselves, this is an evolving area where we're really starting to experiment more and more and appreciate the importance of other stresses apart from mechanical stress to induce positive changes. So I think as our learning or knowledge expands, we should talk about it again.
Yeah, it's funny that, because I think, we both of us probably went through that evolution of, the research was there for mechanical stress and how you create that mechanical stress and what that means. But there are other type of stresses that you probably need to be thinking about applying for what they mean for different areas and systems within the human body.
Yeah, absolutely.
Yeah. Thank you very much for joining us. As always, this episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force platforms, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision making and objectivity. We are no longer guessing. The greatest thing is its ease of use, both for practitioners and clients. There are no wires, no fixed setup, and it is a fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you.